Yeah, can. Thank you, sir, for giving me this opportunity to present my thought in masterclass. So I will take you through a quick update on obstructive sleep apnea, and this update is mainly based on what have been discussed or what discussed in recently Calcutta Sleep Course held in 17th and 18th of December in Kolkata, and there we had many national and international faculties, and they have updated us about various aspects of obstructive sleep apnea. And today I am going to discuss on these three main aspects. One is important changes in the pathophysiology of OSA, and my main discussion will be focusing on this important aspect of pathophysiology of OSA, and this is based on the palm scale approach. I will also try to cover a little bit on important changes in the diagnostics of OSA and important changes in the therapeutics of OSA. So we were fortunate enough to have Danny Eckert among us in our conference, who proposed the Eckert model of OSA based on this palm scale approach. But before we discuss this palm scale approach, we first have to know what was the classical approach before that. There are a few important rules to understand this approach. Is that so we have a drive of respiration. This is known as the neural drive of respiration. And this neural drive of respiration in the awake state is actually dependent on four factors. So one is the chemical drive, second is the mechanical drive, third is the metabolic drive, and fourth is the cortical or the arousal drive. So suppose there is a car, and this is in the awake state, we have four engines for that, or one sledge is being driven by four horses, four horse cart. But when you're falling asleep, this drive is mainly dependent on the chemical drive. So now we have only one engine or one sledge or sledge of one horse only. So definitely the drive becomes much lower during sleep. And there are also a few important other rules that the chemoreceptor sensitivity during sleep is very low, or our sensors react in a delayed way during sleep. And this rapid change of state actually produces ventilatory instability. So we have a different uh, control of respiration during the awake state and during the sleep state. So if there is a rapid transition between the awake and sleep state, that produces actually ventilatory instability. So suppose one car is or one sledge is run by four horses and suddenly one horses. So if you do it very suddenly, then definitely there is going to be an instability. So that happens especially during sleep, during the rapid transition from the wake to sleep and sleep to wake. And this respiratory drive is not only has an effect on respiration itself, but the muscles of respiration, that means the diaphragm, the intercostal muscles, the upper airway dilator muscles also receives its tone during the neural drive of respirations. So this upper airway muscle opening is related to the neural drive of respiration. So these are the important rules before we understand the important pathophysiological aspect of obstructive sleep apnea. Now, the classical model was that uh, in OSA patients, there is an anatomical obstruction, and this anatomical obstruction is being dealt during the awake state by the action of the upper airway dilator muscles, and which keeps the airway open. But when we fall asleep, these muscles also fall asleep and upper airway closes. That's we have an obstructive event, or there is airway narrowing causing apneas or hypopneas during sleep. But first, Raymer in 1978 opposed this idea, and this is known as Raymer's model. He measured actually the pharyngeal pressure, which is actually the endoluminal pressure in the upper airway during sleep, and the tone of the genioglossus muscle, which is the main upper airway dilator muscle. So what he saw is very interesting, that during the beginning of obstructive event, there is loss of muscle tone and there is increased negative pressure. But as the negative pressure becomes more, the muscle tone in the genioglossus actually increases, but it is not sufficient to maintain the patency of the upper airway, and ultimately the upper airway collapses until there is an arousal. This arousal gives extra drive or extra force, or this is an extra engine to the upper airway dilator muscle, which gives more tone, and so that it can prevent the upper airway collapse. So according to them, they propose that only cortical arousal can balance the forces between increasing negative suction pressure of the pharynx and genioglossus activity stabilizing the upper airway. That means, according to them, a cortical arousal is necessary to terminate the obstructive event during sleep in OSA. But this idea was challenged in 2000 by Eunice et al., and this is known as Eunice model, because they have seen that many patients of OSA have stable breathing without any arousals. And we have also seen that sometimes we have a cluster of obstructive events during polysomnography, and in between there is a stable breathing for a prolonged time. And in that time also, Jordan et al. Confirmed that the genioglossus activity during stable breathing is increased relative to the period of repetitive events. What that meant is that if the genioglossus activity can be increased to counteract the obstruction, that can actually prevent recurrent arousal and recurrent obstructive sleep apnea or recurrent apneas and hypoapneas during sleep. So they propose that the OSA patients can overcome obstruction without an arousal, and if they can do that, that can produce a stable breathing even in OSA patients intermittently. So they propose these theories that, or these hypotheses, that the response to obstruction varies from patient to patient and to the same patient within the same patient from time to time. And actually, the upper airway obstruction is a prerequisite. There must be an anatomical obstruction for obstructive sleep apnea to occur. But the response to obstruction actually is actually the major determinant of severity of OSA. So even if the obstruction is there, the response to obstruction determines when the patient will have these obstructive events during sleep, or whether or not. And arousals actually can perpetuate more obstruction, because arousals will bring about ventilatory instability. Patients is going into arousal, and sleep very rapidly can produce ventilatory instability, as we have mentioned previously. So arousals can perpetuate more obstruction in OSA patients. And based on these ideas, Eckert proposed these four traits or four phenotypes of OSA. So one is the anatomical obstruction, that is the prerequisite arousal threshold, loop gain, and the muscle responsiveness. And this PCRIT means P for palm, P in palm, PALM means P for the PCRIT, A for the arousal threshold, L for the loop gain, and M for the muscle responsiveness. So the PCRIT is a anatomically compromised and collapsible upper airway. The low arousal threshold means waking up prematurely to airway narrowing. High loop gain means having an oversensitive ventilatory control system, and inadequate muscle responsive means inadequate responsiveness of the upper airway dilator muscles to negative pharyngeal pressure. So what is the peak rate then? The peak rate is the pressure at which the airway collapses to the negative forces during sleep. So we know that in OSA, we should have an anatomical obstruction. This anatomical obstruction is known as a static obstruction, which is fixed. Either it can be a skeletal obstruction or it can be a soft tissue obstruction. But this obstruction is not the everything in OSA. Actually, the dynamic obstruction or the physiological trait that is determined by this arousal threshold, this muscle responsiveness and loop gain actually causes more obstruction in that already compromised airway, and that actually precipitated the obstructive respiratory event during sleep. And they propose that if the peak rate or the critical closing pressure of the airway is in the positive value, that means the atmospheric pressure is 760 millimeter of Hg. If it is plus 2, 762 millimeter Hg, then even during the awake state, the patient have a propensity have a collapse of the upper airway, but that is being kept open by the very high action of the upper airway dilator muscles. But when the patient is falling asleep, definitely these kind of patients are going to have obstructive sleep apnea. So peak rate +2 or in the plus range, definitely patient have OSA. Peak rate -5, that means 755 millimeter of Hg. These patients are resistant to have obstructive sleep apnea because the peak rate reserve is so high in these patients. So plus peak rate, definitely obstructive sleep apnea, minus no obstructive sleep apnea. Now, the important concept is the loop gain in the palm scale. So loop gain is an engineering term which has the three following components. One is the plant gain, second is the controller gain, and third is the circulation delay. So what is a plant gain, or what is a loop gain actually? Suppose there is a plant which produces carbon dioxide, and this carbon dioxide production is kept in a fixed rate by a controller which actually monitors the plant to see what is the rate of production of carbon dioxide. If the rate of production of carbon dioxide is very high, then it sends signals to the plant that you decrease your production, or if the rate of production is very low, it sends signals to the plant that you increase your production. And this is done by the way of ventilation. Now, what is a gain actually? A gain means output by input. So if we are talking about the controller gain, then the output is the ventilation, input is the CO2. That means controller gain means VE by CO2, and plant gain means here the output is CO2 and the input is ventilation, CO2 by VE. So actually this V by CO2 or CO2 by VE should be ideally around 1, and if it is not 1, then there is a ventilatory instability, and that suggests that the production of CO2 is out of proportion of the ventilation, or the ventilation is out of proportion of the CO2 and that brings about a ventilatory instability, and this is known as a loop gain. And then what is a lung carotid delay? So lung carotid delay means what is the blood gas tension in the lung is not reflected in the carotid, because the sensors which senses the carbon dioxide tension in the blood, or the oxygen tension, or the metabolic parameters are not located in the lung. They are located in the carotid arteries or the aortic bodies. That is a different side from the lung. And it takes some time for the blood to go from these lungs to that sensors. So this any increased delay actually, suppose there is an increased delay, what is happening in the plant cannot be monitored properly by the controller, or what the controller is doing to the plant as a feedback loop is also lagging behind. So if there is a delay, there is the plant controller mismatch, and there is a ventilatory instability. And this loop gain is the main cause of chain stroke breathing or the central sleep apneic breathing in heart failure patients. But in obstructive sleep apnea patients, this is also a very, very important phenomena. Now, arousal is also very important for sleep apnea to occur. So arousal threshold means the stimuli or the trivial stimuli, or how trivial is the stimuli to wake up the patient. If the arousal threshold is low, the patient wakes up with very trivial stimuli. If the arousal threshold is high, you need a higher stimuli to arouse the patient. So arousal threshold is not a unique phenomena. Arousal threshold changes continuously during sleep. It is low during the N1 sleep and N2 sleep, and it is highest during the N3 sleep. And sleep progression for following arousal is also different. What is the sleep progression? That means if the patient is awake, then when he is going to fall asleep, how quickly the stage 3 can be achieved, or how quickly the deep sleep can be achieved. This is given by the sleep recovery. And there is one measurement for that, that is called the ORP9, that is the average sleep depth for 9 seconds following arousal. So if the sleep recovery is very poor, that suggests that the patient is sleeping in a very low arousal threshold state, and from that he can be waked up very easily, and that can bring about a very hypersensitive ventilatory control system, or destabilizing the ventilatory control, bringing about ventilatory instability. So low arousal threshold causes frequent arousals and ventilatory overshoot. So when we are being aroused from the sleep, We have the four control of respiration of the neural drive, like what I have told before. And there is ventilatory overshooting. This ventilatory overshooting causes lowering of carbon dioxide, and there is again ventilatory dampening. So recurrent arousals means ventilatory overshooting followed by ventilatory dampening, and that causes rapid change of ventilatory state instability. Regarding the muscle responsiveness, one of the important concepts is that after discharge. So what is after discharge? A phenomena where muscles continue to be active for a while after the stimulus has ended. What that means is that the upper airway dilator muscle have a tone, and this tone depends on the various factors during the awake state and during the sleep state. So when the upper airway is opened, this due to the action of this upper airway dilator muscle tone, this tone, if it stays for some time, that actually prevents the next event. So upper airway dilator muscle is preserving its tone for some time, means there is reduction of the events. So continued activity beyond this hyperventilatory phase would protect against recurrent obstruction, and this is known as the after discharge. Measure to promote after discharge may reduce OSA severity. And after discharge was recently found to be enhanced in N3 sleep. So we all know that in N3 sleep, obstructive respiratory events are very less. And this is one of the mechanisms by which this N3 sleep stabilizes this obstructive respiratory event. One is this after discharge, and second is this very high arousal threshold. So that's why we have lower number of obstructive respiratory events during the N3 sleep. So based on these approaches, Eckert actually proposed this PALM scale, this three PALM scale 1, PALM scale 2, and PALM scale 3. In PALM scale 1, the patient usually have a very high anatomical obstruction, or so that means a very high peak rate. And here the treatment is mainly the CPAP or the positive airway pressure and major anatomical intervention. That means we have a very high static obstruction, and that has to be overcome. Palm scale 2 is further subdivided into palm scale 2A, which is more likely of the palm scale 1. And here also we have a major anatomical obstruction. And here various procedures actually reduces this peak rate by various levels. Suppose if you have done a mandibular advancement, that reduces the peak rate by 2.3 centimeter. If you have done a UPPP surgery, then that reduces the peak rate by 3.3 centimeter. Supine to lateral position, that means positional therapy reduces peak rate by 2.2 centimeter, and a 17% reduction of the BMI actually reduces peak rate by 7.5 centimeters. So there is a huge reduction after losing body weight in the peak rate value. Palm scale 2B is more of physiologic than the anatomic obstruction. Here, non-anatomic intervention may be beneficial. Suppose if the patient is having a very high loop gain, then we have to stabilize the ventilatory system. How it can be stabilized? Now, oxygen therapy reduces loop gain and OSA severity by approximately 50% in patients with high loop gain state, or acetazolamide reduces loop gain and OSA severity by 50%. And this controller gain also can be stabilized by increasing a little amount of CO2 or dead space into the NIV circuit, or roughly doubling the genioglossus EMG activity by myofunctional therapy reduces the peak rate by 1.6 centimeter of H2O. And those patients having a very high, very low arousal threshold, a standard dose of azathioprine increases arousal threshold and reduces the OSA severity by 45% in patients with OSA with low arousal threshold. But the main caveat here is that we do not have any clinical model till to point that which component is producing or playing a role in these patients, whether it's a very high loop gain or it's a arousal threshold. So we do not have a robust clinical model to interpret this theoretical model till now. The palm scale 3, it is more of physiological trait than the anatomical trait, and they have some vulnerability of upper airway collapse, and OSA severity is usually mild to moderate and usually severe in the REM sleep, where the muscle responsiveness is very low, and the non-anatomic anatomic trait is mainly corrected with some physiological measurement as already been dealt. So now that is all for the pathophysiologic part of OSA. Now a few points about the diagnostic, few rapid points. We all know we have four type of PSG available: type 1, type 2, type 3, and type 4. That depends on the number of channels we use, whether we use a monitoring or not. And recently, American Academy of Sleep Medicine does not support the type 4 device for home sleep apnea testing. And for home sleep apnea testing, they have released some guidelines. This is given in this guideline. You can have a free access to that article. And from the COVID time, we have a lot of emphasis on the home sleep apnea testing. So apart from the polysomnographic based devices, we are now shifting to other technologies, like we are shifting to peripheral arterial tonometry with oximetry and actigraphy for sleep apnea testing. We are shifting to the heart rate variability principle and the ballistocardiographic principle for sleep apnea testing. So these are different technology apart that is different from the PSG based approach that we are using at present. And these are the various home app sleep apnea testing devices available. But what has been discussed recently in our conference is that this type of devices is WatchPat 100 and 300, which is known as Itamar 100 and 300. These are new kind of devices which are being used in home sleep apnea testing now, and these are based on these principles of peripheral arterial tonometry, uh, pulse amplitude, and oxygen saturation. Here you can typically see what happens during this kind of studies. When there is an obstructive event, there is a sympathetic discharge. This sympathetic discharge actually causes vasoconstriction, and there is a lower peripheral arterial tonometry amplitude. This is given by the lower amplitude, and that lower amplitude is also accompanied with a higher heart rate due to the sympathetic discharge, and there is a deep of oxygen saturation if this is associated with an obstructive respiratory event. So these three together actually constitute a respiratory event index rather than the AHI in this HSAT device or home sleep apnea testing device, and this can give the REI index throughout the night. And if you use actigraphy, that will give you the sleep time or approximation of the sleep time. Now we also have the night owl with us. This is a very sleek devices which can be used for home sleep apnea testing. This is a disposable multi-night home sleep apnea test based on the peripheral arterial tonometry or photoplethysmographic principles. And this is certified by the various agencies, and this can be used for the multiple nights to test obstructive sleep apnea. The main advantage is that the night-to-night variability is being taken care of by this kind of devices. But there are contraindications of these devices. So these devices performance can be impacted by alterations in the sympathetic response or impaired perfusion at the peripheral finger tissue. So as a result, it cannot be used for those patients who are using some drugs which modulate the autonomic nervous system, like alpha blockers or beta blockers, or those patients having a Raynaud's phenomena or peripheral vascular disease. This type of devices cannot be used. And obviously, this type of devices should be used in only those patients who have a very high likelihood of having obstructive sleep apnea by a stop bank questionnaire, and they should not have any other cardiorespiratory disorders, and there should not be any other sleep disorders. And these all fulfills the criteria of this home sleep apnea testing. Now, regarding the diagnostics, a few brief points. Uh, so we know that what Dr. Ghoshal always says, that CPAP is a very big pill to swallow, and compliance is a big issue in CPAP. Uh, rather than the reactive compliance, what we are practicing now, or what is the standard practice, a proactive compliance measurement by telemedicine-based approach can actually increase the CPAP compliance rate. And this is one study which has shown that how this telemedicine-based approach, where we can have the data or the cloud-based data, you can have an access anywhere from the world, from the patient's machine, and you can contact the patient based on this data. This proactive management actually can increase the CPAP compliance in OSA patients. And based on these recommendations, American Academy of Sleep Medicine also recommended use of these telemonitoring based devices, at least during the initial part of the CPAP initiation, because that will increase the compliance and that can actually improve the future compliance also, and can reduce the termination rate and improve the CPAP uses in our patients. This is how we do the telemonitoring. You have access to the whole data from your computer anywhere in the world. If it is cloud connected, this is the patient's name are given here, and the time of uses is also given here. And there are various icons which can give you an idea about the uses. If it is a green, that means the patient is using it properly. If it is red, that means the patient is not using properly. If lower yellow portion means in spite of using the HI is high. And if you click any of this data, you can get a full report of the patients. And from that, you can contact the patients telling your usage is not proper, or you have to tie your mask properly because there is so much leak in the mask. And these efforts actually, these inputs actually to the patient increases the CPAP compliance. And during the COVID time also, these telemetric CPAP devices were used for the longitudinal CPAP titration. What we are doing at present, the classical CPAP titration is a one night, but you can do a longitudinal CPAP titration through these telemetric devices. Uh, Telemetry devices, and this method was actually became popular during the COVID time when we did not have access to our labs. And though the recent ASM recommendation has not endorsed this kind of CPAP titration method, but actually I think in future it will come in a big way, because you can do a longitudinal titration for so many days and you can get the patient's feedback, which is very important to increase the CPAP compliance. So to summarize what we so far have discussed, that we have discussed the palm scale or the Eckert model of OSA. We have discussed about some newer home sleep apnea testing devices, and we have also discussed telemonitoring of PAP devices. Thank you for your attention.